So one of the questions, and I'm not sure, I guess for both of you to answer, is how can overall survival be the endpoint when patients move to other medications, or if the medication is so successful that endpoints are not met? So how is one being measured?
So that's a very good question. I think now that we have so many different agents that in sequence improve survival, it is hard to have an overall survival endpoint. But I'll tell you why I think it's especially important with immunotherapy. So in the targeted therapy trials with sunitinib and pazopanib, axitinib, they found that they couldn't, after time, really improve overall survival. And so the primary endpoints really had to be progression-free survival. If we look back, though, and say before the era of the targeted therapies, what was overall survival like with interferon-based and high-dose IL-2-based therapies? And then we do a study that compares what overall survival is like in the targeted therapy era. I mean, no doubt we are seeing that when given in sequence, these agents are improving overall survival. The one agent that was able to definitively show it in the phase 3 setting was temsirolimus, which is an IV mTOR inhibitor, but it was given in the poorest of risk patients that had several poor prognostic factors, clinical factors that said they're not going to do quite as well. But to take it back to immunotherapy, I kind of alluded to it a little bit in that I'm not quite sure whether response rate is really the best marker for effectiveness with these agents. If you look at vaccines, at like Provenge, which is a prostate cancer vaccine that's FDA approved, multiple different immunotherapies, we oftentimes don't see the response rates and the progression-free survival benefits, but then in large phase 3 studies, we can see these overall survival benefits. And it may be because it does take time to actually harness your immune system to build so that dendritic cell goes and takes that tumor protein and shows it to the effector killer T cell. That T cell then has to proliferate and make multiple copies of itself. And then those T cells have to go find the tumors at the different sites and do their work. And that takes time to get that tumor back to a point where it's sort of stabilized, and then even more time to get it back where we're kind of showing significant degrees of elimination. I took out a slide that would have really been perfect to explain this concept. It was the immunoediting concept that I think Dr. Hellman sort of described a little bit earlier today. But that's why I think immunotherapy takes time, and we're not necessarily going to grasp the effect with response rate and progression-free survival endpoints that have been used in our traditional therapies.
Great comments. I have nothing really to add to that.
Okay.
Yeah.
There are actually a few questions on talking about histology and if there were ever any varying results based on histology for RCC, and that many of the studies for immunotherapy actually excluded the non-clear cell. So can you speak to both of those concepts?
Sure. It's a very relevant question, and it's something that really irks me a little bit. We really have the preponderance of data for immunotherapy, for novel immunotherapy in the context of clear cell renal cell carcinoma only. We don't really have much data to support the use of these agents in papillary kidney cancer, in chromophobe type kidney cancer, and other disease subtypes. So there is good rationale, I think, to potentially do this. So Sabina Signoretti at your center has actually put out some nice work looking at the immune profile and PD-L1 expression in non-clear cell histologies, and actually found that there is expression of PD-L1, seems to correlate with poor prognosis across these rare subtypes of disease. I hope this really prompts some work looking at immunotherapy in this context. I will say there are alternatives to immunotherapy, however, for those diseases. So let's take papillary as one example. Papillary kidney cancer represents about 10 to 15% of all cases. The underlying biology of papillary is being better and better defined. We think it's driven by a molecule called MET. There is a trial that's underway right now, which is sponsored by AstraZeneca, looking at an agent called volitinib, and there's a limited number of centers that have this available. That's a trial that I would certainly encourage participation in. There's also a trial which I'm heading up within the Southwest Oncology Group, or SWOG, which is going to look at an array of different MET inhibitors and compare that to the option of sunitinib in patients with papillary disease.
It's a very good point. And we do actually have a small subset of patients that in the Genentech MPDL 3280A, that antibody to PD-L1, they actually is the only phase 1 trial that allowed non-clear cell patients. And there were a certain degree, I think it was like 17%, but don't hold me to that one, of patients that actually did have a response with non-clear cell disease. And so patients with non-clear cell RCC can respond to these agents. But we need much bigger subsets. And again, whether response rate is really the ideal marker of benefit remains an outstanding question.
Great.
Are the vaccines or immunotherapies being looked at in the adjuvant setting for RCC?
Go ahead.
There was it was the G250 antibody, which is an antibody against CA9. That criteria that we used to, it's a membrane glycoprotein that is at higher levels on kidney cancers. And so there was a big adjuvant study there that did not pan out. We actually, in terms of other adjuvant studies, right now we know from, I think, more than 7 adjuvant clinical trials of interferon and IL-2 based studies that they did not show a benefit in addition to nephrectomy. A bunch of us in the cooperative group setting out of ECOG, and it'll be with SWOG and Alliance and the Canadians, are proposing to study nivolumab or other PD-1 antibodies in the adjuvant setting. And so there's been a lot of intense discussion about what is the ideal clinical trial for our patients to really test the concept of whether we should give it'll probably be a trial where everybody's going to get nephrectomy. They have at least stage 2 disease, making them high enough risk that we're going to subject them to an additional therapy. And then after nephrectomy, we'll randomize patients to getting, whether it be 6 to 9 months of IV, say nivolumab, for example, versus placebo. And so that's sort of the main backbone of a trial like that.
So excited about that study. And Lauren, I think you're heading that up, right? So it's going to be fun to see it pan out.
Is there any thought of combining IL-2 with the other immunotherapies to make each more effective?
I haven't been impressed by combinations of lower dose IL-2 with other immunotherapeutic strategies like interferon. And I have to say, I would have reservations about combining high dose IL-2, which is already quite toxic, with PD-1 inhibitors. I haven't personally seen any experience put out there looking at that combo. Lauren, are you familiar with any?
No, I was actually just speaking with a colleague at Emory. His lab is looking actually at that very question, and I think there was some talk of doing it in melanoma, and oftentimes we look to the melanoma people who have done it and say, oh, that looks interesting, and should we bring it this way? So I wouldn't rule it out. I just have to think about how do we do it, because as you eloquently showed, high-dose IL-2 is still a drug we should use in our armamentarium. It is no doubt the only drug that's been proven to actually cure patients who have metastatic disease, but for every 100 patients you have to treat, it's only about 7 patients that'll have that durable, complete response. And of those 7 patients, I think the Fife data showed that only 50% of them will actually truly equate to a cure. That's a very small number to subject patients to such intense toxicity. So until we have better biomarkers to predict response, it's tough to combine it with other agents that might increase the toxicity.
And for people that have been previously treated with IL-2, is it still optimistic that they might respond to the other immunotherapies?
I think so. We don't really have much data. That would be a great subset analysis in some of the earlier trials, but it's such a rare number of patients, I think, in the U.S. that get high-dose IL-2. But I'm sure that We should do that. We should do a retrospective review of that. It would be very interesting.